Hi, I'm Suyin, and I'm the host of this podcast. And this session, we are very excited to explore the concept of hospital at home. We have two guests on the podcast, or rather, my co-host is Dr. Michelle Tan. You know her as the lead of the SGH at Home program. And we're also very excited to have Dr. David Levine. So I'll let Michelle introduce herself, and then she will introduce Dr. Levine.
Thanks, Suyin. I'm Michelle. I'm the person that has been ad nauseum talking about hospital at home in Singapore General Hospital for the last 3 years. So I'm really privileged today to be invited to join Suyin in a podcast to interview Dr. David Levine from Boston.
Thank you so much for having me both. It's really exciting to be here. I'm David Levine. I'm a general internist at Brigham Women's Hospital and Mass General Brigham in Boston in Harvard Medical School, where I get to do a combination of both outpatient care as well as inpatient care. But fortunately, I'm very privileged that all of my inpatient care is only in people's homes, where I no longer have to necessarily work day in and day out in the brick and mortar. And I'm a health services researcher, where I get to do a lot of research on questions in the home at Ariadne Labs, as well as our division of general medicine.
Okay, so I think what's really exciting for me, David, is that I'm finally meeting someone that actually has experience implementing hospital at home. A lot of times, for me, it's really meeting people with theoretical knowledge, policy knowledge, so that's really exciting. I just wanted to find out from you, what's your hospital at home setup like?
Sure, yeah. So we've evolved, right? So we've been doing this for over a decade now. We started out with just the first randomized control trial in the US, and we've since evolved into a multi-site, multi-hospital program throughout our entire enterprise at Mass General Brigham. And so today we have 70 beds that we're able to take care of at once in the Boston area. We've expanded to the entire Boston metropolitan area, and we've been able to essentially create sites throughout the area, not just at our hospitals, but also at things as simple as like a garage in order to be able to reach our patients' homes in a 20-minute response time. So our patients come from the emergency department, or what we call the A&E here, and also from the general ward. We can't take patients directly from home, even though we'd like to, but there's certain regulations that prevent us from doing that. And we take patients home. They get 2 daily nurse visits every single day from either a nurse or a paramedic. We have specially trained paramedics in the US called community paramedics that have extra training. They're not 911 or EMS paramedics. And then every day our patients get what we call a provider visit, which could be a physician, a physician's assistant, or a nurse practitioner. And so 2 daily nurse visits, 1 daily doctor visit. That visit can be by video or physically in the home, depends on what the patient needs from the doctor or the physician assistant or nurse practitioner. And then we bring all of the care that you'd expect to get in the hospital, whether that's consultant, specialty consultant care, oxygen, intravenous medications, all the different monitoring like telemetry that we have. Our patients are all continuously monitored. So they'll be on either an armband or a patch on their chest that continuously monitors their vital signs. And then we have a 24/7 team, right? Because then when you're in the hospital, someone's there 24/7 of the time. And so we think the same should be true for home hospital. And so we have a team of community paramedics that are available around the clock that have a 20-minute response time to people in their homes to help kind of fix something that's wrong, if it's a beeping pump or new pain or bleeding or something like that. And then we stay with the patient for their acute care period. And then once they're ready for discharge from kind of the acute care episode, we discharge them back to the community.
Wow, that's really great. And just to give our viewers an idea how this compares to Singapore, what is the population of the metropolitan area of Boston like?
In terms of like the size?
The population that you serve?
Yeah, so probably similar to the populations you serve here, to be honest. So we serve mostly an older adult population, average ages in 70s to 90s, I'd say. And the kinds of conditions that we're treating are really the bread and butter of, we started out bread and butter of internal medicine. We've now moved to a lot of the bread and butter of general surgery. We also have neurological diagnoses. We can dive into those if we're interested. But the bread and butter for internal medicine are infectious processes, so complicated UTI, pneumonia, things like that, cellulitis. Then we do exacerbations of heart failure. We do exacerbations of COPD and asthma. And then we've built additional capabilities also. So we also now do diabetic ketoacidosis for our endocrinology friends. We are able to do AFib with RVR, rapid ventricular response at home because of our telemetry monitoring, and have built a kind of a whole pipeline of novel diagnoses as well now, where we can even partner with our obstetricians on postpartum hypertension pathways, and then partner with our neurologists on things like multiple sclerosis admissions and so on.
So it's been really, I know we use the term very often and overuse it, but it's a paradigm shift, isn't it? The concept of delivering care, hospital-grade care at home. Although you can always argue that decades ago, centuries ago, really that was how physicians delivered care. How do you decide what level of care or what sort of diagnosis to go for if you were building up a program like this? Because some people say, well, you should just do the easy, the low-lying fruit, just do, so fever where you have what the cause is a UTI, they just need to do antibiotics. Or should you go for where you actually need, it's actually high-intensity care, but they're going to be better off at home? Transplant patients, immunosuppressed. How do you decide?
It's a great question. So when we started this, right, home hospital, people often forget, home hospitals have been going on for decades around the world. The United States was actually pretty late to the game. We've been doing it in fits and starts since the late 1990s, but in Australia and France and the UK, it's decades and decades of work. So we started building on those shoulders of those giants, right? There was a decent number of publications to sort of understand the patient phenotype that they were taking care of, and the tools that they used to take care of it. So we started with that. And then what we really did was we wanted to build on that using a technology-infused approach, right? Because in Australia and elsewhere, they were not physiologically monitoring patients in a continuous manner. They weren't bringing point-of-care blood systems to the home. They weren't bringing POCUS to the home, and so on. So when you add those capabilities, you can all of a sudden take care of new kinds of patient phenotypes that you hadn't been able to do before. So we actually have a pretty structured approach to figuring out which new diagnosis we want to add. And we look at, very simply, we look at patient volumes to start in our catchment area. And we say, okay, did 50, 500, 5,000 patients come to us last year who had a UTI? Okay, well, if it's 5,000, that looks pretty good. And then we look at and we bring a whole stakeholder population of clinicians together. We bring the nurses, the docs, the social workers, the coordinators, the physical therapists if it's applicable. We bring everybody together. We even bring patients together with it. And then we say, okay, so what does it take to deliver this care in the hospital right now? And if we can portabilize that, miniaturize it in many cases, and bring that to the patient's home, that's another box that we can check. And then finally, we look at some additional logistics, cost effectiveness of it, and then the people power that's necessary for it, right? Do I have to have a nurse there 24/7? Well, that's not going to be effective then. I can't do that. But if I can check that box also in terms of people power and cost effectiveness, then we can actually start to build the detailed pathway. And we have kind of a whole templated system that we use to look at what's the new equipment that we need, what are the new trainings that we need for our field team, what's the patient education we have to deliver to kind of teach folks like it's actually okay to get this care in the home. And so that's really how we try to fix and figure out what are the best set of pathways to go on, kind of starting from a historical perspective.
And technology infused, I really like that. What are some of the technologies that you feel have really enabled this model of care to take off?
There's a lot of controversy about that, I think, right? So I have colleagues in Australia who say, David, you do all this technology stuff. It's all fancy pants. Like, you don't need any of that. You just got to take care of patients. And I said, I agree. Like, I don't like bells and whistles either, but can you take care of AFib with RVR at home without telemetry? And they're like, no, we never take care of that at home. You got to stay in the hospital for that. But I said, well, no, you don't. Not if you have telemetry for your patients at home. And so I think some of the top things that have really changed the paradigm for our ability to deliver care at home is physiologic monitoring, continuous physiologic monitoring. So being able to have your continuous heart rate, continuous respiratory rate, continuous temperature, and then your telemetry have been some of the key pieces that have really pushed us to be able to say, like, there's not any difference between the monitoring that I can deliver in the hospital, in the brick and mortar, and the monitoring I can deliver at home. And in fact, it's oftentimes more facile. Like, we can deliver a better footprint in terms of there's no wires coming off of you, right? It's all a wireless system, very much passive. You basically forget you have it on, and we're able to then collect the data. So I think that's one really great piece of technology. The second one is sadly not new, but we don't use it in the brick and mortar, and that is point of care blood testing. Right, so I can get a basic metabolic panel and an H&H faster than you can in this amazing hospital we're sitting in right now. I can get it in 2 minutes in a patient's home off of just a very simple capillary stick. That's pretty extraordinary when you're talking about diuresing a patient with heart failure, for example, or making sure that a new antibiotic isn't causing an AKI, an acute kidney injury, for example. And so being able to get my blood tests on the same visit right when I'm in the patient's home makes logistics so much better than having to bring blood back to the hospital, wait for blood to process, go back to act on the blood, and so on. When you're in the brick and mortar, it doesn't matter as much, right? Oh, they need a little more fluid, they need a little more furosemide. I can wait to get my labs later. You don't always have that luxury, or it really slows you down in the home. And so I think point of care blood testing has really been a big factor. I'd say the third piece of technology that has helped us a lot, and there's many, but I'll just kind of, the last one would probably be point of care imaging, right? So we have the ability to bring in X-ray to the patient's home. We can bring in ultrasound to the patient's home. And again, really speeds up our ability to run any sort of diagnostics or any sort of changes in management that imaging would help us to create. And there's a lot more, but I'll stop at just 3.
So thanks, David, for sharing all that. And it's a lot of technology that in Singapore we have actually explored for our hospital at home as well. But this is the part where I think I'm invited to be the Debbie Downer. A little bit of a contrarian. Okay, so I do think technology definitely is an important enabler, and we do use quite a fair bit, such as remote vital signs monitoring for our patients. But I can also see that it can be a tripwire as well. For example, unstable Wi-Fi connection, patient forgets to charge the device. We had a situation where the point of care testing device failed at that juncture where we were at the patient's house, and it was one of those bad vascular access, very difficult to get, but yet the result was critical. So how do we kind of, navigate that so that we can scale this care model and not compromise patient safety and care?
It's 3G. That's actually good enough for what we need typically. Oh, but maybe we can't get that signal. Okay, well, then we need to have a 4G antenna system that we can bring to the patient's home to raise a better signal. Oh, we still can't raise a signal. Okay, no problem. Then we cascade to the next thing, which is portable broadband satellites. Which actually is, the cost of that has almost plummeted now. I'm going to guess that you do not have that cascade system in your home hospital. I don't have that system in mine, but that's actually something we should build. If we truly are having connectivity issues, we should have that redundancy system built in. We've gotten to the point now in our program in Boston where we have a 3-part SIM card that goes in. And so it flips between the different carriers. And again, forgive me, I don't know if that would help in Singapore or not. But it flips between the prevailing carriers. So it's Sprint, AT&T, Verizon, and it flips back and forth till it finds the best carrier signal for that home. And that has actually, for example, been a redundancy factor for us to help improve connectivity. It's not perfect, but it's a fun engineering problem of saying, we have this tech issue, the technology is not delivering what it should, how can we back it up, basically? And I think we still have work to do in our field to create more redundancy.
Yeah, that's a great idea, actually. We have currently 4 telco carriers in Singapore, soon to be 3, 2 are merging. And yes, I will explore that. Thanks very much for the idea. Yeah.
So it's just problem solving, right, in that sense. What about the people aspect? Did you get pushback either from patients who may have said, well, I feel safer to be in a hospital, I'm not sure what I'm doing at home, or the provider aspect? People said, no, don't do this to my patients. Yeah.
So sure, ×2. Yes. And I think they're 2 different stories, because it's interesting, right? So we can start with the provider area, and I'll be curious to hear kind of what the experience has been here. We have an uphill battle, right? Because none of us were trained that home hospital is a disposition, that home hospital is a safe, effective model of care for acutely ill adults. And none of us were trained in like the specifics of it either. It's also a similar story I tell, right? We have this amazing accelerometry data. I was never trained as a medical student how to look at an XYZ accelerometry plot and know that my patient's getting better, but actually I've taught myself how to do that through years of like looking at them. And so the providers it's an uphill battle for us, because we're basically, someone's coming in and telling us that, no, you should do it a totally different way than you were trained. And that is anathema to us, right? Like, we do what we were trained to do. Unfortunately, like, we are very much animals of tradition and patterns and things like that. And we are basically trying to turn that all on its head and say, by the way, the place that you were taught to deliver care is the wrong place. And it's much better to do it in a place that you've never even heard of, which is home. And so providers, I think the eyes got real white when I started this work, and I'm sitting in the emergency department, the patient's septic, but we know what the source is, and like, I'm gonna take you home. It's all right. You're gonna do what? Like, are you crazy? This patient's getting fluids, they're getting antibiotics, they're getting oxygen. You can't take them home. I'm like, you just named 3 things that are my bread and butter. Like, I can do all 3 of those things just fine at home. And so we've had a very long campaign. Again, it's been a decade of us doing this. I'd say we're really only like still halfway there with our provider teams. But it's been storytelling. Sadly, like, doctors listen to stories more than data, just like regular humans. Like, hearing that your patient actually thrived when they went home instead of did poorly is really powerful. So telling stories about patients, either your own patients that you sent to home hospital or just patients in general that you think are like yours, has been very powerful. And then, and we share our data a lot. And we actually challenge people, like, are you sharing your brick and mortar data as much as we're sharing our data? Do you even know what your 30-day readmission rate is? Do you know what your mortality rates are? Things of that sort. And most doctors are like, no, I have no idea what my rates are. But so I think sharing data, sharing stories, has been a big part. And then the biggest thing, honestly, has been to make it easy. Right? We talk about the easy button. Like, I want to just, most of us want to press the easy button. We want to go home to our families. Like, we don't want to stay longer and longer and longer in the hospital. And so trying to make it as seamless as possible to send someone to our team at home as it is to send somebody upstairs from the A&E is a big deal. And so we've worked a lot on that too.
Well, it's really reassuring for me, actually, because so in Singapore, we're quite new to the game. We've only like 3-4 years in. And I think the experience that on my journey is actually very similar to what you've described, actually. When we first started out, exact same thing happened to me. Acute care at home, are you crazy? Same thing. And I find that even with patients and clinicians, right, you have to earn their trust one case at a time. Mm-hmm. So what surprised me is, so Singapore General Hospital is a tertiary and quaternary hospital. So initially everybody started out saying that, why don't you just take the simple cases, the rhabdomyolysis, the dengue fevers, which is something that's common here, or the cellulitis. Sure. But then we realized that that's not the patient population in the hospital that really needed help most. It was actually the complex patients, the cardiothoracic patients, the renal transplant patients, the liver transplant patients, for example. Those were the ones that needed help. So I think the experience we had was initially everybody was a little bit concerned, even our team was wondering. But when we broke down the care provisions that we had to provide, we realized we could match those care provisions. Mm-hmm. And when the patient had a good experience, and we made sure to feedback and keep the primary specialists in the loop, and they were always part of the care team in the care decisions, right? I think we built that trust, and then subsequently, with one case, you gain strength, and then you help another case, and then now they are actually, some of the transplant teams are actually one of our staunchest supporters. So I'm very reassured and very inspired that the experience that you had was very similar to ours. So definitely that would help us drive on more.
Yeah. I think another thing that's interesting is we probably don't protocolize enough care in medicine for the physicians. Honestly, a lot of literature about this too. Like when we take physician decision-making away from the physicians, oftentimes the outcomes are better. Like I personally believe that we don't really need physicians to manage community-acquired pneumonia, for example. It's a very standard thing. There's very standard processes. Yet for some reason, when we have physicians involved, for example, blood cultures don't get drawn before antibiotics. Like, how did that happen? That's a very simple guideline-directed care, right? It just doesn't happen. I think if we were to take physicians away from some of that decision-making, leave physicians for the tough stuff, but for the bread and butter things that are very much just algorithmized, and frankly, transplant care is very algorithmized, even though it's a complex process, I think we'll see better outcomes. And so the reason I say that is because we have had a lot of success in algorithmizing some of our home hospital pathways, especially for some of the newer pathways. Give you an example of postpartum hypertension. I actually didn't even realize this phenotype existed, but birthing patients will spend days on the labor and delivery ward waiting for their blood pressure to normalize, just taking oral medications. I said, first of all, I'm not quite sure why they need to stay admitted, but okay, they're staying admitted. We can do this in home hospital, no problem. And we have a very simple algorithm. It just says, if blood pressure this, give this, double it to this if it's still not controlled, and so on. And it's a very simple process that they follow on the floor, on the ward, and we're able to do that exact same thing. And once you algorithmize that, it actually makes bringing new cases to home hospitals so much simpler. There was a great presentation actually on this from an Australian team who does hospital in the home for surgery. They had the hardest time getting patients to the home hospital program from the surgeons. Why? Because every surgeon does it different. Every surgeon needs X, Y, and Z. They all need to have control, etc. But if you make a general algorithm that all the surgeons agree to, it's no longer their choice. It's no longer even they don't even need to weigh in. It's like, oh, post-op day 0, this, all done. Perfect, going home. We've got the algorithm. By the way, you agreed to the algorithm. And thanks so much for doing a great surgery and being in the OR, which is exactly where you want to be. You don't want to be on the ward anyway. We're going to take care of your patient now following the algorithm you developed. And all of a sudden, this Australian team showed their volume of these cases just skyrocketed because everyone's following a path.
I'm going to take you up on that. Almost philosophically, where are we going to draw the line between the benefits of checklists and algorithms and protocols?
Yeah.
And will we lose the thinking and the nuancing that really is medicine?
I don't think so. Not for the simple stuff. Not for the bread and butter stuff. We are way too human. We miss things, we forget things, we think we know a better way, but there are just so many studies that show that we don't follow goal concordant care. We don't give people GDMT when they should get it. We don't do cancer screening when we should. Like the list goes on and on and on. And I've sadly had to publish a lot of these papers showing, at least in my country, the terrible rates of like following guideline-based care. And so I think for the easy stuff, we need to like step away from those cases, frankly. There's some really beautiful examples of this in some of our large health systems in the US. Like for example, Intermountain is renowned for showing that community-acquired pneumonia does not need a physician to actively manage. And however, I don't think that works for patients who don't fit the guidelines. That's where we need experience. That's where we need physicians to come in and tweak the guidelines, tweak the treatment, change the dose here, use a different medicine there, and really hyper tailor the care. And so I think that's where we need us. And that's where we need expert nurses and expert social workers and the whole team, the pharmacy team, everyone to come in and kind of change that care. But I don't think for the vast majority, frankly, of presentations that we often have a lot of value add.
So, David, all this talk about checklists and algorithms has me kind of curious, and I've been dying to ask you this. I know in your previous lifetime, you were a chemistry teacher.
Yeah.
Yeah. Now, that experience as a chemistry teacher, how did that help you in this role in building hospital at home?
A great question. So the answer is yes. So I used to be a Chicago public schools teacher on the west side of Chicago. It was a very tough neighborhood. And it's the first place I ever did professional home visits. It was as a teacher. And the reason, unfortunately, was that my kids would get shot walking out of school. I've been taught that there's no such thing as a GSW in Singapore, which is amazing, but not the case in the United States, as you all know. And so my kids would get shot walking out of school. They would be pregnant before they wanted to be pregnant, and they would all become temporarily homebound. And if we remember, that is actually the place that home hospital started. It was for patients who were homebound, and for mostly geriatric cases. And so I was very privileged to visit. I visited these students' homes because I wanted to keep them up to date in school. Because if you didn't pass chemistry in Chicago Public Schools, you couldn't get your high school diploma. And so I would visit them in their home, and it was the most amazing experience for me because I realized that if you went to someone's home and you saw where they were, who they were with, what they were dealing with, like, you got it. It was just like this automatic opportunity to understand, like, wow, I get you now in a much deeper way than you could ever understand a student who's inside the four walls of your classroom. Didn't matter you asked them questions, didn't matter if you screened them, right? That's what we do in medicine. We screen you for your social determinants of health. We screen you for this. Doesn't matter. When you go to somebody's home, and you know this, Michelle, having gone to patients' homes, it is just so apparent most of the time what's going on and how you can help and how you can interact quickly. And so I took that lesson very, very much from being a high school teacher. I carried that through in medical school, did a lot of community-based work, and then actually in residency in New York City started a training program for like how to teach home-based care and house calls, basically. I had an opportunity to work with really masters of home-based care in New York City, and then was in really the right place at the right time during my fellowship in Boston to start home hospital there. So really kind of took that all the way through.
Yeah. Well, actually, thanks for sharing, because I feel the same way. So, Suyen, I would highly recommend you do a home visit, because sometimes you walk through the door, you kind of like, I understand why you don't care about your HbA1c, because you don't even have the money to pay the power bill to get the power on, you know. So I totally get that. Though one of the things that I constantly face in my work, and having you share this experience, I think you might face the same dilemma, is that when you go to a patient's home, and this patient may be perhaps socio-economically more disadvantaged, the home environment may not be conducive to safe hospital-at-home care. So just like last week, we had a patient who was a hoarder, and his house was so packed with junk that the nurse had to sit outside his house at the corridor at the front door and give the intravenous antibiotics through the front door. Now, this patient sincerely really wanted to recover at home, but how do you decide, where to draw the line? Like whether, the home environment is something that is unsafe, or how can we make it safer with the resources we have?
Yeah, it's a great question. I think I'll break it down in two ways. One, I think we always have to ask ourselves the question of where is this patient going when we're done with the acute care? It's really hard to ask that question sometimes when you're in the moment, right? When you're in this patient's home and it's an infested place, or it's someone's hoarding or something like that. But if you step back and say, okay, this patient were in the brick and mortar right now, and I finished treating them 4 days later, am I going to discharge them home? And if the answer is yes, then my ethos is that our home hospital team should do everything we possibly can to treat them in their home for those 4 days, because we're going to send them right back there. Now, if you answer no, and like, no, this place is completely inhospitable and like no one can live in this home, then okay, like then that's where I draw the line, because we're not going to return them to their home. Maybe we're going to force them to live in a nursing facility or, you know, all sorts of different social care options. But that's kind of where I make that decision. But I think that brings up a really important point that I'm sure your team feels as well, is that we have an amazing privilege and responsibility to act on the things that we see. And we have this crazy cool opportunity to do that we never get in the brick and mortar, right? We can do, I love doing kitchen walkthroughs, for example, where like you go through somebody's fridge and kitchen. And
I do bathroom walkthroughs.
Bathroom walkthroughs too,
yeah.
Yes. And so you get to talk about and see things that like a registered dietitian's dream would be to get to do something like this, right? And we have the opportunity to see that the cupboards are bare and like there is no food in the house. Or the number of times that I have gone down in patients that live in public housing and talked to a super and been like, you know what, that window is completely broken in that patient's home and that is not to code. I really suggest that that be fixed by tomorrow. Otherwise, we're just going to have to, you know, cite that. And wow, the next day, the window's fixed. And so like our team can give the patient a lot of agency because we come from a position of power and they don't have that power, but we can bring them that power when we're in their home. And so I think it's just this awesome opportunity to intervene on a lot of the social determinants of health. It may not be instant, right? It may not be, hey, the window got fixed by the next day, but it may be that we set them up with certain social services that the hospital never would have been able to consider because they never been able to see it or think about it. Again, no matter how much we screen for these things.
Yeah, I think it's really powerful because detractors of hospital at home sometimes say, oh, you know, equity, you know, you are pandering to people who can manage, who are of a certain level, who can manage with the monitoring technology, or they have ability to have food prepared for them at home. But the fact that you've highlighted that actually that is an opportunity to step into the patient's environment, it also puts the onus on us to act on that. And it really gives us that window. Do you have a lot of difficulty connecting our patients locally with, you know, where they need help beyond the medical help?
Locally, no, because I think the way these social services are structured, as you know, Agency of Integrated Care consolidates all the social services in Singapore. So in Singapore, all the agencies used to be separate, but now they've been consolidated under one agency called the Agency of Integrated Care. So pretty much we go to them and they'll be able to link the patient up to the necessary care. So usually not, but I think the thing is that you can advocate for a patient. You can say that, hey, you're a hoarder. This is a health hazard. It is a fire hazard. Let me do something. But the patient also has their own agency and autonomy to say that, no, I'm perfectly happy. I don't want you to do anything. So I think that's the part that I struggle with most actually, is that how to balance trying to be helpful, doing something that we know that would be good for the patient health and outcome, but then respecting the patient's own autonomy and their right to have these circumstances. Yeah, we get that a lot.
I think it's a balance, right? Sometimes we think we know what's better for patients, and frankly, we're probably wrong, right? Like, you're 90. You've made it 90 years like this. Like, who's me to tell you that, hey, by the way, you got to get rid of like this throw rug that you keep tripping on. Like, I've been walking on this rug for 90 years. I don't need you to tell me to move the rug. So I do think it's just an interesting balance. But I will say to your comment that it's funny, in the States, I actually get it from both sides, which makes it even more preposterous. So people will come and say, you've developed home hospital for the rich people. It's this concierge care, get it all in your home, you know, like it was 150 years ago. You must be very posh to get that. You must need, you know, assistance and all these fancy things. I'm like, that's completely not true. Let me come show you. But then the reason it's completely not true is people come from the other side and say, oh, you developed home hospital for poor people to kick them out of the hospital, to make way for all the rich people to have beds in the hospital, didn't you? I'm like, how can both of those things be true at the same time? They can't. And it does speak, I think, to the equity of the care model. Like, this is care that all folks can access. You don't need to live in a palace. It doesn't actually even matter much, the type of house you have. And we actually did a study on the national claims data in the States, and we broke down the sorts of people in that trial. So we looked at all comers, and then we also compared it to folks with a disability. So you can see that in claims if folks are disabled. We looked at folks with a very low socioeconomic status. And then we looked at people of Black and Latino and Latina race ethnicity. And we looked across, and what's really phenomenal is that you don't see any differences in those groups when it comes to mortality, readmission, use of skilled nursing facilities, and so on. That is like really good news, because that means that this is a care delivery model that actually delivers equitable care. Whereas sadly in the United States, at least, and I don't know, but I would assume there are some inequities in the Singaporean health system. We know that there are drastic inequities in those figures among those groups in traditional brick and mortar care, but we're not seeing that in home hospital care. So I think it does speak to the general equity of the care model.
How do you bring hospital at home to the next level? What's the next level for you?
Yeah, so many levels. There's so many next levels. I think on a very practical standpoint, the next level is really just scaling it as the default option in the United States. If you go to Barcelona in Spain, there are 6 major hospitals there. Guess how many hospitals have a home hospital program?
You're going to say 1?
6.
6? Oh,
All
that
of
works.
them. Yeah, it's the way that they deliver care there. That would be a dream for me if in the United States, every hospital that you went to has a home hospital program, and that is the way, by default, that you get your care. And if you can't get it at home, okay, you'll stay. That would be that paradigm shift at scale in the United States. And I think would be taking the care model really to like that population level. I think in terms of more minute kind of change, like the way that I'd like to see changes happen for home hospital is really, and don't laugh, but is through the use of drones. We create a massive logistics problem in home hospital. We need to get all this stuff, all these people, the right place at the right time for the patients. That is hard. And so we've actually started some of our first pilot flights looking at how can we use drones to really refashion the ability to get that stuff to the people at the right time, particularly in urgent situations where plans change, right? This is acute medicine. Orders change all the time. Patients' status changes all the time. And so when the plan changes, that can throw kinks in your logistics. And so we're now looking to use drones to essentially simplify a lot of the transport that we need to do. And so I think that'll start to be next levels when we're at a population scale, when we're simplified logistics. And I can go on and on about different kind of smaller technologies, but I think those are the bigger trends.
I'm really excited because I'm the person that goes to all these retreats and go like, why can't we have drones in Singapore? Because on YouTube, you watch all those videos with Zipline and the good work that they're doing with drones. So I think you probably spend a lot of time in the Marina Bay area. You realize this country is covered in high rises and skyscrapers. Yeah. So do you still think that drones would have a impactful role in logistics, healthcare logistics in Singapore?
I do. Yeah, absolutely. I don't think that that's actually a big challenge. We already have the technology to deliver in those kinds of areas. We're flying right now in Boston, which actually one of the toughest. It's Class B. It's the Class Bravo airspace. I've had to learn way too much about flying. I'm not a pilot or anything, but it is one of the most challenging places to fly in our country, and we're pretty optimistic that we're going to be able to do it. I think there's lots of really creative ways, even in a skyscraper dotted country like yours, to still make that happen. Everything from medical delivery boxes outside of every person's skyscraper to kind of delivery to specific points, to recognition of people or QR codes when they're there, to also, delivery directly to healthcare personnel, type of thing. So I think there's lots of options. Obviously, it needs to be done very safely. Obviously, there needs to be a lot of change management, but also like culture adjustment, right? To not be afraid when there's a drone whizzing outside the window or something like that. Again, not a problem in Singapore where we're going to shoot down the drones, but a problem in the U.S. And so I do think that the tech is there. We need to get the regulations right. Like, we need to make sure that we're regulating it appropriately, that it's safe for everybody. But we've been working actually quite closely with the FAA in our country. They call it drones for good. I think it's very, very positive. They're very excited about it. They weren't excited about it when it was a drone delivering you your burrito. They're like,
That's
no.
drones for bad.
Yeah, well, it's drones for why? Like, we don't need that, But this has the potential to be kind of life-saving, and so I think there's a really good opportunity.
Oh, thanks for sharing. Yeah.
Yeah.
We
Because I
need
think
drones for good.
We need drones for good, that's for sure. And I've also seen, I think it's from your lab as well, the use of virtual reality to train patients or to help them troubleshoot when they're dealing with equipment. And so we really we watch you, we stalk you, to see how you're kind of pushing the boundaries. But really, I guess what we hope for, just like we hope with telemedicine, is that we no longer have to talk about it, because hospital at home should really be standard of care, right? Exactly what you said. It should be, why would I need to have you in hospital? And then I'll bring you into an inpatient facility. So how far are we from that, Michelle?
Augmented reality. So that's something that was interesting when I was reading up about your work. I have to say, we have been approached a few times with various augmented reality headsets, and I kind of didn't quite get how it could be helpful in our care model. So maybe that's something that you could illuminate for me.
Yeah. And then I want to hear your answer to her question about how far are you from the default option here. But so, yeah, I think I'll give you an example. So just to give a simple example, and right, maybe you're wearing the headset and I'm rock climbing in the mountains. I don't know. No, I'm actually doing my job. I'm back in clinic or something like that. And I say, Michelle, I want you to take a drink from one of the cups. And you're like, David, there's 3 cups on the table in front of us. I don't know which cup you want me to take a drink from. Like, no worries. And I circle the cup. And you're like, okay, I'll take that one. That's the simple example, right? But now let's say, you're in a patient's home and you've never been trained to do an incision and drainage, an IND, right? But we've got an abscess over there and we need to drain it. I could come out and do that, but maybe I don't have time, or I've got 13 other INDs to do over there and I need you to help me with that one. Ordinarily, you would never do that. You'd be like, nope, not qualified, not trained, I don't know what to do. And patient would get delayed care. Instead, you're wearing your augmented reality glasses and I can step by step help you through that procedure. I can verify that you're, let's just say, cleaning the site correctly. I can verify you have the right equipment ready. I can draw for you exactly where I want you to cut. I can show you how to express it properly, how to make sure you're deep enough, and so on, and lead you through the procedure, essentially. I think it's going to completely revolutionize the way that we're able to be present when we're not actually physically present. So I think we can help with task guidance for like our fellow clinicians. Maybe you were a nurse or a paramedic in the home, and I just upskilled you to do that IND. Maybe you're a family caregiver, and all I need is to take out your IV, and I can discharge you. Well, I don't need to send a nurse for that. If you put on your glasses, and I'm looking at the IV, and I say, I want you to put your fingers right there, and I want you to pull like that, and I put an arrow this way, and now I want you to put pressure right there, and I put an X right there, and I'm watching you do the whole thing. No, you all of a sudden just did what only nurses are allowed to do all of a sudden, but you're a family caregiver. So I think there's lots of clinical applications where we could think of essentially upskilling people in the home being present in a totally transformational way. I think it's like the new version of telemedicine that we haven't gotten to yet, and really also increase the patient experience, right? I don't know how many times this has happened to you, but oftentimes I'm staring at someone's ear when I do a video visit with them. Why? Because they can't hear the call. They're like, what? And you're just looking at their ear. Contrast that with putting on glasses, speakers right in the ear, huge screen in front of you so that you can see your provider or your physician. It's a totally different experience. And so I think there's a lot of opportunities with the AR technology that I think will just totally transform our logistics, our efficiency, our experience, both for the clinician and for the patient and their family caregiver.
Oh, right. Thanks for sharing.
Yeah.
I think I was seeing it more from the provider point of view, like AR for us, but actually I never thought about maybe the applications on the patient.
Yeah.
But while you were describing all that, it did make me realize that maybe from a clinical governance and policy point of view, we also need to look at it differently, because traditional governance and policy would say that, no, the healthcare team must do this and do that. You cannot let patients touch it. But then if we are going to revolutionize things and then push this model forward, then I think those policies will have to be relooked at.
Oh, absolutely. Yeah. There's scope of practice issues very much bound up in this. We handled this at a non-tech level with our paramedics, for example. I think I mentioned to you, we use community paramedics. These are not EMS paramedics. They used to do EMS. We gave them about 150 extra hours of training, things that normally paramedics don't do, like IV antibiotics, urinary catheters, end-of-life care, things like that. We up-trained them, and then essentially their scope of practice got a lot bigger with regulatory changes from our EMS team, our Department of Public Health. It took like half a decade for me to get those changes in Massachusetts, where I live. I think it's totally feasible in Singapore, by the way, to kind of change the way that EMS works, and diversified our workforce, enabled us to then keep paramedics in the field in their job longer. They would have burned out. They're like 50 years old. I can't do this anymore. No, I can do community paramedicine instead. So it kind of gives people a new lease on life type of thing in their role. And then they're so good at working in home hospital programs as a result. But I think you're spot on that, like, we do need regulatory changes for some of what we do. What you and I do a lot of times is in the gray, right? Like, we don't really have a policy for controlled substances to transport from the hospital to the home. Again, I know it's not as big a deal in Singapore as it is in the US, but we live in this gray area for a lot of the work we do. And so when we're talking about giving people, upskilling people, it again changes. And so we do need regulations to catch up to what we're doing. And I think AR is a great example of, like, AR guided IV placement, or AR guided this, or AR guided that. That's going to be a whole new category of stuff that can happen now, that there are zero policies for that written. I guarantee you at any Sing Health institution, certainly don't exist in my institution either right now, that we are going to need to make.
I look forward to it happening in my lifetime.
Let's do like less than 5 years. Come on.
Yeah, we'll make it happen. So we've talked everything from innovation to implementation. Implementation science is a whole new thing by itself. But you haven't answered my question. How far do you think we are, and how can we?
We are but an infant in this journey. He's 10 years in, and he's still fighting all these battles. But definitely, it is a rewarding journey, and I don't think we're going anywhere. So I do think that we know what path we have to take, and all these challenges that we face, they are not insurmountable. And I do think that for Sing Health, for Singapore General Hospital at least, the challenge we were given, so we are a 1,800 bed hospital. So the challenge we've been given is, could you substitute 10% of your hospital bed with this? And then have it as a default option for a set number of conditions, as you mentioned. We've taken some baby steps, and I think we're getting there. We're currently at currently we're not 10%, we're like 1.8% perhaps. Yeah, but definitely I'm quite inspired to continue on. And all these challenges that we face, really, it seems quite normal. In fact, it means that we're doing it right, correct? Yeah.
Absolutely. Yeah.
I think so. My question for kind of the future is whether there is a way to leapfrog some of those issues. I don't have the answer, because I do hear over and over again from like amazing leaders like you that like, yes, we have the change management problems. Yes, we have the problems with the providers won't send us patients. Yes, we have problems that patients say no to us because they've been trained for 100 years. They have to get care in the hospital. Yes, we have logistics problems. Like, my question for the future is, when the next person starts a home hospital program in their health system, like, can they leapfrog the decade of work that folks like I have had to try to do to just turn it on? I don't know the answer to that question, but it'll be interesting. We are working, to your point, a lot on implementation science, because that's an implementation science question, right? Like, can we create the right toolkits, the right methods to really leapfrog, like, frankly, the slow pace that we've seen in some of these places? I think folks here are actually toward that path, frankly. I mean, you've been at it only a couple years, and you already have, in all of Singapore, like, multiple programs that are getting quite large quite fast. It's really very, very impressive that you should really feel good about.
Right. Thanks for the reassurance.
We should teach it in medical school too, so that they don't come out
It's such
thinking
a good,
this is...
we have a pipeline problem right now, right?
Yeah.
So we need to insert it into nursing school, into medical school, into pharmacy school. It can't just be the one lecture that you give or that I give. The whole medical school, all 4 years, is like, oh yeah, home hospital, 35 minutes. It needs to be, you rotate in it. It needs to be, you learn the skills for it. You learn all the technology for it. It's a huge deal that we need to make happen.
Have you been able to introduce it in the curriculum at Harvard?
No, not more than that one lecture. No, it's sad. And there's actually all sorts of concerns about medical students being out in the field by themselves in certain neighborhoods. And so there are some interesting kind of staffing dilemmas for that. We have been very effective at introducing it for our residents. So our residents rotate in it, and I think have a great experience, and I think learn a lot. But getting it at that ground level in medical school, nursing school, pharmacy school, super, super important, and we don't have it there yet. And I think the other piece is to create training programs for it on, if we can't get in at the ground. And to say, like, well, what does onboarding look like for a home hospital physician or a home hospital nurse? That is done so differently all across the world right now. And thinking about ways to standardize that, right? There's one master's program for home hospital care in Spain right now. Seeing a lot more of that will continue to improve, I think, the training situation and the pipeline problem that we have.
I think you should start by rotating the rest of us through your hospital at home program.
Sure. You just let me know when you're free.
Tomorrow.
Okay.
We'll do that.
Wow. That's a good start.
We've had a fantastic, absolutely fantastic discussion today. I really want to thank you for sharing all these insights with us, and we really hope to continue working with you on this, and send Michelle over.
Yeah, well, Boston's kind of far.
Tell me about it.
But we hope you enjoy the rest of your time in Singapore.
Thank you very much for having me. Great discussion, and just look forward to the continued success here.
All right. Thank you
so much.
Thank you.